and the director of the WHO Collaborating Center on Global Governance of Antimicrobial Resistance. He equally at the same time holds a courtesy appointment as a professor of health research methods, evidence, and impact at McMaster University. So it's a man of multiple caps, actually. You don't just see those heroes, they're supermen because they're able to do multiple things at the same time. Solve problems in the communities in different areas at the same time, not just here in the country, not just here in Toronto, but in the whole world. He's an international lawyer. You heard me mention barrister at the start. Licensed not just here, but equally in New York, one of the two biggest cities in the world. I don't know, Shanghai may say no, we are lying, but some of the biggest cities in the world. When it comes to his research, he leverages various methodological approaches to craft global strategies that better addresses transnational health threats and social inequalities. There are two key words here. Do not say national, transnational. Do not only look at the elite group, social inequalities, looking at marginalized group. That's one thing about Professor Barrister Hoffman, that if you want to take from here, he's someone that cares about the communities that no one else cares about. He look at the future of being human, not from the point of view of somebody living in Toronto, but from the point of view of someone living in Iqaluit or Nunavut, a community that nobody will ever look at, or my own community where I grew up. So please, today we will have the honor for Professor Barrister Hoffman to share with us the future direction of surveillance in Canada and the whole world. So please put your hands together and welcome Professor Barrister Hoffman to the stage. Thank you.
Thank you. Oh, thanks so much. So kind of you. That was way too kind of an introduction, Jude. Thanks so much. The admiration that was mutual, Jude, of course, being one of the superstars at York University, and delighted, Jude, we got to finally meet each other in person today. So thanks so much for this kind invitation. It's really quite an honor to be able to be here today at the Fields Institute at this conference. I see there's lots of people joining online. There's lots of people here in person. And so I'm really excited to give you a bit of a window into some of the issues that you've probably been talking about for the last couple of days, but from the perspective of the federal government. So I myself, well, as Jude mentioned, I'm actually coming from the academic sector myself. I've been a researcher most of my career, but always working with government. And what was new for me is 6.5 months ago, I was asked to move into government. It's my first time being a public servant, which has been quite an adventure. But it's been actually quite a humbling adventure to be able to serve people in Canada, as well as help advance Canada's role in the world when it comes to public health data and surveillance, along with some other areas, including risk assessment, behavioral science, knowledge mobilization as well. So my goal for today, I don't have any equations on my slides. Although my PhD was in health policy, focused on evaluative science and statistics. So most of my PhD coursework was actually in statistics in the stats department. But I won't be sharing any of that today because I think the value add that I have at a meeting like this with, well, mathematicians focused on public health is trying to bring a bit of that policy government of Canada lens about how we're seeing these issues and where we think things need to go. Though in sharing that, I share it in a humble way, recognizing that many of you are at the cutting edge of where we need to go. And I recognize that we in the Public Health Agency of Canada, Government of Canada more broadly, need to benefit from your wisdom, from your insights, from where you think we need to go in order to get there together. So that's my part of my goal, and why I was so appreciative of the invitation to be here is, yes, I'm happy to share some thoughts from Government of Canada perspective, but even more so, selfishly, I'm really hoping that all of you will be willing to sort of join us in this journey to figure out the future. And I certainly want to hear from you because I need to benefit, and my colleagues need to benefit from your wisdom. So with that, specifically, let's think of this as a 5-part play or a play in 5 acts. First, I'm planning to just take a bit of a look back on sort of 20 the last 20 years and how surveillance or public health surveillance is different today than it is, let's say, when the Public Health Agency of Canada was first created 20 years ago after the SARS outbreak. Second, I'm going to sort of share an update about where we're at right now. I'll focus in on the Public Health Agency of Canada's Detect, Understand, Act framework that was funded almost $500 million of investment in the last budget, so budget 2022. Third, highlighting some thinking about where the future of public health surveillance needs to go in Canada. And then I'm going to hone in on two different aspects of that you've probably been speaking about earlier in the conference, but I'll emphasize it from the way the government of Canada is looking at these issues. The first is around the need for surveillance systems to work across boundaries. So I'll be talking about One Health in that context. And second, our surveillance needing to look across borders. And so in that respect, we'll talk about cultivating global sources of data. So that's my roadmap for today, but very much looking forward to the conversation with all of you to come after. So first, looking back at 20 years, it's interesting when you think of sort of how public health, how data, how computing, how technology, how public expectations have changed in the last 20 years, and wow, has it been quite a difference. So if we're just comparing sort of when the Public Health Agency was created 20 years ago to now, it's that pace of innovation, it's what we can now do with data, the abundance of data. It's just, I think, a completely different world. And so to the extent that today's surveillance systems, to the extent that most of them were designed in an earlier period, it then, I think, behooves us to take stock then of all the changes that have happened, and then to think about how do we need to redesign our approaches to surveillance, as well as the mechanisms through which we do it, that take full advantage of the huge opportunity posed by this world of data, this world where we recognize that a lot of public health of people, such as those in Canada, are influenced not only by things happening in the health sector, but by both, beyond our species, but also in other sectors within our species, recognizing that the kind of insights needed in order to tackle public health challenges of the future are not only coming from public health professionals, are not only coming from surveillance systems that are run by public health. I think the COVID-19 pandemic really brought that to the fore, whereby it was very clear that our traditional systems were not all serving the needs that people expect of their government, of their public health professionals, of their communities and businesses. And people want to be armed with data, and the kind of data systems that we'd had weren't up to the task. And so when thinking of all these things, and I'll do sort of then and nows on a few different areas, just to hone in. One of them is very much about that communication piece. It's recognizing that back 20 years ago, there was, I think, a culture in public health around publishing very technical briefs and reports, and there wasn't the expectation of public health to be communicating directly with citizens in ways that citizens want to be engaged. It was more sort of an expert-driven approach, maybe at a podium at a news conference, more often through denser technical reports. Fast forward to today, social media, the presence that our chief public health officers, chief medical officers had at certain points in the pandemic every day in front of the cameras. It's a totally new world. And just to give you a visual, this is nicely on this slide. It's highlighting sort of the Public Health Agency of Canada's very first public-oriented communication for citizens about stroke, just one issue. You look on the left, so that's what we did 20 years ago. The most recent example of our public communication on stroke is on the right. Now, both are serving the same intention, right? It's to inform Canadians about the risk that stroke poses and how this is very much something that people need to be mindful of, take those steps, no smoking, eating well, exercise, living in healthy environments, but a very different way of communication, fundamentally changing then what people are expecting of our public health surveillance. Second is around health equity. What's clear is 20 years ago, equity was a consideration. So there was, it was sort of something that, it's one of many things. Whereas I think in the context of this pandemic, but also in the context of recognizing that our current systems are not serving everybody, I think equity today is at the core. and needs to be at the core of public health surveillance. And there's that expectation. I think early in the pandemic, for example, a lot of the data that was being presented about who had COVID, who was vaccinated, it was sort of very much general population, and citizens mobilized and demanded better. And over the course of the pandemic, being able to do data disaggregation, but also building in equity into the design of systems slowly was being improved over time. And so I think that is very much sort of a game changer and something that we have to do even better as we go forward. Third, then and now, is around the scope of surveillance. A lot of the initial work in building up surveillance systems was very much focused on infectious disease. Of course, we still have a lot to do. This conference focused on early warning systems. I'm sure most of the focus has been on infectious disease. But of course, we also need early warning systems for non-infectious diseases, as well as earlier indicators of disease that might come, including infectious, like surveillance in the environment as well as among animals. And in terms of another big shift is moving towards integrated surveillance. 20 years ago, a lot of different surveillance systems set up as silos. But again, the COVID-19 pandemic really highlighted, we don't just need to, in order to inform action against a pandemic like COVID, we don't only need surveillance systems that show us who has COVID, we also need systems, and they need to talk to each other about who's been vaccinated for COVID. What are the ICU availability in each different area? What are the critical care capacity? Because noting exactly how many beds doesn't mean there's people to staff those beds. And it doesn't mean that hospitals don't have some flexibility around, for example, canceling some elective surgeries, but then that creates problems down the road, like the kind we're seeing now. So it's a much broader picture that needs to be painted here in order to inform action. That is clear, and the expectations for those linkages are present today. We're not necessarily present 20 years ago. We're not in the same way. I'll just skip that. And then second last one, it's around the types of data that we're drawing on to inform public health surveillance. 20 years ago, there was talk of course, transitioning to electronic health records. That was viewed as the future. But today, not only are we more so there, but we are seeing that there's just an abundance of very helpful sources of public health data. Things that we wouldn't usually talk about or describe as public health data. I'm talking about, for example, cell phone mobility data. I'm talking about web searches, things that 20 years ago we wouldn't have necessarily designed our systems to be looking at to inform public health action. Today, that's the expectation, that we're looking at all these things, and we need to get there. And then finally, into my last then and now, it's looking at sort of the global scope. And so 20 years ago, there was already the Global Public Health Intelligence Network. It was created in the late 1990s. That's one sort of marquee Public Health Agency of Canada initiative. But the sense about the importance of looking across countries and ensuring we take global approaches wasn't necessarily as energized as it is today. And I won't go into that into detail now because I have my fifth act in this 5-act play will be focused exactly on that. Now, of course, when we think of all these then and nows, each one is both an opportunity as well as a challenge. The opportunity, of course, is that with more data, with opportunities for greater scope, with recognition that this is a global issue, with citizens demanding greater efforts and better efforts to communicate with citizens from public health, all of that is an opportunity. And that's really exciting. Doing it is hard, really hard. We're trying to figure it out. I think in some places we are succeeding. I think the pandemic proved to be an accelerant for some of these things, both rising expectations from the public as well as rising efforts to meet those expectations. But certainly, as I said at the beginning, we have a lot of work to do. We need people like you to help us get there. So let me go to where we are going right now in terms of trying to address some of those, challenges and opportunities. And so the present is very much within the Public Health Agency of Canada. We're just one part of the system. But for us, we're very focused right now on modernizing our public health surveillance infrastructure. And we're doing it really through 3 different kind of thrusts right now. First is really about delivering on commitments to strengthen the core. We recognize that a lot of our current systems, we have 64 different surveillance systems. A lot of those systems were designed decades ago. Quite a few most were designed about at least 20 years ago. And so as a result, the way they were designed is not necessarily reflective of where we would want to be in 2023. Of course, we all want them to be, but now there's an opportunity to actually strengthen that core through new investment that's come. The second then is around improving performance overall. Some of that, for example, includes achieving interoperability, moving to the cloud and other things. And then third, it's really about trying to become proactive, trying to think about where do we need to go next, working with people like you and partners across the country and indeed internationally to think about like, what does surveillance need to look like in 2030? Not just about like, what should we expecting of surveillance in 2023? Let's start to look a little bit to the future. And what should that future state look like? And how do we work with partners to collectively get there? So that's sort of the current activity focus. All of this is, it's the reason I'm saying and honing in on this activity is because we have funding from Parliament to do this. In budget 2022, there was almost $500 million given to the Public Health Agency of Canada to enhance its ability to detect, understand, and act on public health threats. And there are different sort of actions within this, we call it DUA, our Detect, Understand, Act framework, DUA. Within this, there's a series of different actions that we're committed to doing. Some of them are, for example, about revitalizing the Global Public Health Intelligence Network, so GFIN. Other aspects are, for example, expanding surveillance in newer areas, like all of our wastewater surveillance and the scaling up of that is funded through this effort. And then additionally, one thing that I'm really quite proud of at the Public Health Agency is we've really upped our game when it comes to integrated risk assessment. So within my branch at the agency, there's the Center for Integrated Risk Assessment. And essentially what we've done is we recognize that there's different risk assessments happening on very specific issues across public health. We are specifically using the latest methods to actually provide an integrated view of it in order to inform joined up action. And so we're sort of within the agency, but also increasingly starting to work with provincial partners to try to take a broader view of the myriad of risks that we face in order to bring them together and figure out, okay, where do we really need to act? Where are the levers and who do we need to engage beyond sort of the usual suspects? Because a lot of these actions that are needed to address these public health risks, especially if we're thinking more upstream, are needing to engage beyond sort of the traditional public health actors. So that's where, well, I'm really quite proud of that. We're going there. That's an important effort for us. Another thing that's linked to this or enabled by this is we are trying to set at the agency minimum standards for what a Public Health Agency of Canada surveillance system should look like. This is early work. We're still in progress, would welcome thoughts. We are still, for example, are figuring out and articulating what should those minimum standards look like. But we do recognize that we need to sort of build up the floor of what something looks like and what Canadians and others in Canada can depend upon. And then similarly, if some of that then is also about then expanding the range. And so I've mentioned wastewater. I won't go into too much detail about this, but certainly I remember at the beginning of the pandemic, at that point, I was at the Canadian Institutes of Health Research as the scientific director for the Institute of Population Public Health. And at that point, I remember in 2019, we were talking about the potential future of wastewater surveillance, and there was discussion of should we be bringing together researchers to talk about it from a research perspective. And I just remember like 3 months later, pandemic hit, and it's like, forget the research, let's deploy and figure out later if it works. And good thing it did. It's been very helpful in its own ways, but it's a nice example, I think, where the research community really mobilized, filled in a gap on the spot, and because of the urgent need, started to implement and research and evaluate all at the same time. And it ended up being, I think, a huge, huge success in Canada. Now we're thinking of how do we stabilize that? How do we scale it? My final slide for Act 2 in this 5-act play is just honing in on when I talked about integrated risk assessment, there is a certain approach we're taking. Some of it's about having very rapid response. So for example, a new threat comes, whether it's a new variant of COVID-19, whether it's a forest fire, whether it's another kind of threat, an earthquake, for example, or a new disease. Within 3 days, the Public Health Agency of Canada should be able to have a rapid risk assessment that benefits from a range of intelligence sources, including science, but also locally contextualized data, also an understanding of how similar cases have been managed in the past and such. That's sort of where we're going to and developing the processes to do. But the future is hopefully friendly, but of course we all need to work together to make it friendly. And I'd say that we're at a bit of a crossroads. We're still in a pandemic. We've just experienced 3 years of, a terrible situation for everyone, particularly bad for some. And so in light of that, how do we leverage that experiences and all the lessons learned in that pandemic in order to drive the kind of changes to our public health data and surveillance ecosystem that are needed? And so again, when thinking of this particular moment that we have in 2023, I personally see just a whole lot of opportunity. I see challenges, but actually I see a whole lot of opportunity, as was described earlier. There's opportunity for new partners. Everybody gets public health now. We've been talking about public health for 3 years. A lot of people around kitchen tables across the country are probably sick of talking about public health, but they know more about public health now than they did 3 years ago. That is an asset that we need to leverage for advancing public health surveillance in our country. There's new tools, some of which, like wastewater, have been shown to be helpful in certain contexts. Others, like the leveraging of social media, are only getting better as well. Trust and transparency, it's now clear how key that is. Government, for example, public health, academia, we can only move at the pace that citizens will let us. And so what that does is it puts on us a responsibility to ensure that we're transparent about the way that we're making use of data and bringing citizens along and actually empowering decisions to make decisions about their data. And so I think that is something we've maybe talked about. It's become very real for us. And again, an opportunity and a challenge to overcome. Anyway, making use of AI, big data, as well as a big focus on building the workforce needed in order to leverage these tools. So again, anyone working in a university context has a big, big role to play in ensuring we're training folks who can actually help us enter this new era. So looking ahead, I think we need a vision for where public health surveillance needs to be. One approach that we're taking at the agency is we are trying to, and we're just at the very early stages of thinking about even how to do this, is around trying to craft a vision for what surveillance should look like in Canada in the year 2030. The thinking behind that is that a lot of the opportunity and landscape has changed. And if we're just focused on catching up to 2023, yes, that gets us somewhere. But even better is if together with partners, we can figure out where do we all want to get to by 2030. And then again, we can engage a whole broader group of people in actually getting there and articulating what's needed then between now and 2030 to get to where people in Canada should be able to expect of their either government, other public health authorities, healthcare professionals. That's where our minds are going. And so only two of the key pieces already, at least on my mind, are around working across sectoral boundaries and working across international boundaries. Of course, we'll need your help to also think about where else we need to be thinking for the future of surveillance, but those are at least already two that are on my mind. And so to transition to part 4, in terms of One Health, I think probably this has come up quite a bit in this conference thus far, so I will go through this quickly and also to leave time for conversation among us. But I just wanted to emphasize from a Public Health Agency of Canada perspective, this is not a nice to have, this is essential for us. For us to do our job, we need to not just be looking at indicators of health among humans, we need to be looking at upstream drivers of disease where there's sentinel indicators in the environment and in animals, recognizing that human health, animal health, environmental health, intrinsically interconnected and interdependent. That's new or newer for public health. We're going in this direction in a big way. So, and we recognize that we need to move on this. I think just from a very pragmatic perspective, 6 of 7 of the last World Health Organization declarations of public health emergencies of international concern since 2009 have been pathogens of non-human animal origin. 75% of recently emerging infectious diseases affecting humans are of animal origin, and over 60% of emerging infectious disease events are caused by non-human animal pathogens. Point being, if we're listening to the statistics as we should be in this case, it points us in a very, very clear direction. We need to go there. Just one example, live example that's highly relevant in a Canadian context is just how is the West Nile virus surveillance program that is actually up and running. And this is one example where we could, if we could theoretically limit our public health surveillance to humans, that would not be a very effective approach here, especially given we can make good use of surveilling sentinel animals like horses, but also mosquitoes themselves. So already it's one live example where we're already taking a One Health approach and wouldn't be able to do a good job without it. Just highlighting, there's calls internationally moving in this space. The World Bank in particular has been promoting a One Health approach, not just as a basis of this is how we do better, but also from a this is how we save money and, well, this is how we can do things in more cost-effective ways. Partially because it's about leveraging upstream opportunities to prevent things from happening before they incur their human and economic cost. But it's also because taking a One Health approach offers a wider lens on the problem and a wider range of solutions to address it. So that's a key aspect of that. Lots of calls for action, whether it's from the literature, whether it's from Canadian government, whether it's from international sources, and increasing number of global initiatives in this space, whether it's through the UN, whether it's through the academic community or other organizations. Finally, as my last parts of this, I would be remiss if I didn't talk about global work. And I say that as someone who is a global health researcher at the core. I've always been focused on global health work until, well, maybe until my current job 6.5 months ago. But even in this job, recognizing that only 0.48% of this world lives in Canada, that means statistically 99.52% of the new public health risks are going to start outside of Canada. So I would argue a vice president for data and surveillance at the Public Health Agency of Canada is not doing their job if they're not thinking globally and cultivating global sources of data, recognizing where threats are going to come. And so with that in mind, plus the additional fact that Canada is one of the most globalized nations in the world, with some of the highest levels of immigration and immigrant populations, means that we do need to think globally. We have to detect threats globally, we have to understand things from a global perspective, and of course, act globally too. And so one thing, at least my part of this, is very much about cultivating those global sources of data. So it's very much thinking about, okay, how do we better understand what's happening elsewhere, what kind of threats are happening elsewhere, in order to inform our preparation for those threats in Canada, recognizing again 99.52% of those risks and threats are likely to come from outside our country. And so then just to apply a lens then on the existing 64 surveillance systems, and I love that we have 64 systems, there's 64 spots on a chessboard. I don't know if that's, we're trying to think about how we take that metaphor a bit further, but the point though on this slide is only 6 of our 64 systems currently have an international component. I say only because, and I'm not sure there's what a right number is, but I guess my bias came out there as a global person, globally minded person. I was a little surprised to see that it was just 6. So that means 58 don't currently have an international component. But 6 is something to build on, so that's an important start. The good news, though, is we're not alone in the global space, right? So yes, on the left-hand side of this slide, you'll see that, yes, there's 6 existing Public Health Agency of Canada systems or funded systems that are globally oriented. But we also are contributing to and beneficiaries of several global health data partnerships, and we'll continue to work in that space. But increasingly, something we have to do more of, both at my agency as well as all of us, is thinking about what would be currently thought of as non-health data, but yet is highly, highly relevant for health, whether that's education data, that's justice data, climate change data, human settlement data, urbanization data, all of which highly, highly relevant for public health, even if we don't call it or think of it as public health data. It is. And so moving now to sort of the final slides, one thing that I am quite excited about as an opportunity in the short term for cultivating global sources of data is the negotiation of an international pandemic instrument. This is just one initiative of many that's happening right now. This is happening under the auspices of the World Health Organization. This would be a new treaty that countries come together to define. And one of the key issues that has come up in that negotiating process, which is really just starting, is around data and public health surveillance. Basically, how do we have early warning systems for the world as per the focus of this conference? And so I think when we think of where data needs to go and when we think of in a global context, I think openness is then key. We need to ensure that we're taking open approaches so that everyone can benefit, so that we can create innovation ecosystems where others can actually build on that work. And especially speaking from a government agency perspective, a key aspect that we need to do and need to increasingly develop our approach on is how can we contribute to this open landscape so that others can count on us for that data and those innovations, and then others can build on it and take it much, much further based on their own skill set. So of course there's challenges, and just as a joke, I mean, imagine if everything was open, everything was linked, public-facing APIs, and of course adding in some quantum-resistant cryptography, homomorphic encryption for privacy. I know you guys might be working on that. This is how great would it be if our future quantum computers couldn't crack the codes? But I think we could focus on that work, but I also really wanted to emphasize, and I'm humble in saying this to a group of mathematicians, is some of it's really complex and some of it we need your brilliant brains to help us advance the math and the stats around these things. We also, though, need to work on the basics. There's some very, very core fundamentals that are holding us back in the space. It's things as simple as a commitment to data sharing. In the Canadian context, we don't have a world-class health data system. So which is one reason why in the current mandate letter to the Minister of Health, the Federal Minister of Health, the Prime Minister has asked Minister Duclos to help achieve a world-class health data system in Canada, because it's not there. There isn't yet, although hopefully will be soon, a commitment to that kind of data sharing. Even if there's a commitment to data sharing, it doesn't mean the infrastructure enables interoperable data sharing, and that we don't have the data structure, standards and structures to do it. Data standards, and then even if we have all that, the level of data literacy, either in government, in civil society, in academia, in the public, is probably not where it needs to be. So my last slide is just help me out. There's a lot of work. This is a big, ambitious agenda. I think the timing has never been better. It will perhaps never be as good to advance this agenda in our lifetimes as it is right now. So please help us. Let's go together to try to achieve this. Some ideas, there are, FAC is on GitHub, check out our code and such, and contribute. We're also hiring. So in fact, my branch, I think, is the only branch at the agency currently that is expanding. But that's good for folks interested in data and public health surveillance. And there's just a range of opportunities there. And then finally, for the researchers in the room, which is, I'm sure, probably most of you, wanted to emphasize that at the Public Health Agency Canada, we are looking for collaborations with scientists around how we can move forward on the issues that we're seized with. So I think to the extent that there's opportunities in your work to think about engaging fact data scientists in it, I would strongly encourage you to reach out and see if things are possible. So with that, let me end. Looking forward to the conversation, and thanks again for inviting me.
Wow. I think we should clap again, actually. This is amazing. So if I were to take a lesson on surveillance, I think I just got it here. The past, the present, future, emphasis on One Health, not working in silos, because One Health is recognizing that human health is not dissociated from animal and environmental health, not just that it's not a one discipline problem, but interdisciplinary, breaking silos, and a global perspective, which Canada has always taken the lead. So thank you so much. Now I'll open the floor for us to ask questions. We have him here with us here today, so it's time for us to ask our question and get clarification of based on the talk. Yes, please.
John?
Yeah.
Thanks, Stephen. That was fantastic. I have a question about the, first of all, thank you. This was a really great framework. And I'm thinking about the DUA framework, the detect, understand, and act. Now, I'm going to speak on the act piece, and I'm going to talk about this as a clinician who gets called to the emergency department, as an infectious disease doc to see someone who was, I don't know, just in Borneo and who's got this unusual febrile illness. When I think about surveillance and the translation of this information and who are the actors that ultimately need to consume it, there's an interesting paradox around clinicians who, as we all know, are short-staffed and our emergency departments are overloaded. And the cognitive load really makes it challenging for clinicians to have this, as you've highlighted, we are a very interconnected community in Canada, to have this global situational awareness. But as you can imagine, if someone walks into the emergency department, an astute clinician, we often hear this, could be the difference between something getting stopped in its tracks and an outbreak occurring that could affect the whole country. And my question is, I often see that there's a bit of a gap between how public health sees its role and how healthcare sees its role. They both have the word health in them, but they're very disparate communities. The public health view is panoramic. The healthcare view is often myopic. How do we bridge this gap, and how does public health see its role in empowering the frontline clinicians in that ACT framework? To me, I guess I still see a big disconnect between the public health role and mandate and the healthcare role. But it feels to me like this is a very vulnerable point. And how do we bridge that gap? Not to elaborate so much on it, but again, the healthcare sector often is like, well, this is kind of public health's mandate. Public health, I often hear is kind of like, we're not in healthcare. We're not solving the problems in the emergency room. So just curious if you have thoughts on how do we bridge this gap?
Yeah, Cam, thanks so much for the question. It's I think, both one of the most important questions, but also it's so timely considering there are ongoing negotiations around sort of healthcare funding and such happening right now in our country, as we read every day in the newspapers. I think that there are sort of differences. There's different cultures. There's different contexts. I think data can bring us together, and the reason I share that is a whole lot of the data that public health needs in order to do its job is actually coming from the healthcare context. And so when the government of Canada is having conversations about the future of health data, it's actually one in the same, whether it's public health data or healthcare data, it's the exact same conversation. And we're very, very linked up in those conversations, taking a very united approach. And that is translating also into conversations with the provinces and territories. So I think right now, there are separations. How do we, and those are around for decades. And so some of that is maybe even helpful. Some of it certainly is counterproductive. But data can be that uniting element, right? Because if we're going to have interoperable systems, if we're going to have sort of public health data informing clinical practice, clinical data informing public health responses, that if we're able to, through information technology, data standards, through ontologies that reflect these different needs, then that, I think, could be an amazing way to create language by which we can actually work together on the same thing, which is the health of people who live on this tiny blue dot in the universe. Yeah.
Thank you very much. Thank you.
Hi. My name is Domei Chen. I'm actually working on a lot of public health data in the past. And myself I can claim myself is more about like a data scientist in some way. I have been working a lot of like, especially spatial data in the past. So I think you give a very excellent, I think, pictures of like, what's going on there about surveillance systems in the public health. So if my understanding correct, so currently like public health basically trying to use like One Health, like kind of the concept to cover different type of the disease or different health issues related to public health. So I think one of the key issues which we found it is we seems like lack of coordinated the framework to kind of for different organization to either like to submit the data, which everyone either for public decision, like government decision making, or for the researchers to do some of like research work. And we probably all have the experience. We struggled. We said, "Oh gosh, where I can get the data I needed to do this kind of the research, or trying to do this kind of alarm or warnings, right?" And although they have, everyone has been saying now we are data rich, we have big data, but where the big data is and what is the quality, and then how we can get this data, and what is the data standard framework, which, for example, every work like the clinic, public health, and how they are going to submit those kind of information to the surveillance systems, or how even like as the public, the general public, so many social media, right? They have so many of the information there, but how at what kind of the framework we should use it to connect those kind of the data from either traditional way and non-traditional ways. So, and those data can become meaningful data for either research or for the public decision-making, or even the surveillance systems. Currently the PHAC has any of the plans or strategies or framework which is been developing, and then so we could use it as a guideline to everyone?
Yeah, thanks for the question. So what you're talking about is the same issues that have motivated the Public Health Agency Canada to lead for the government the development and negotiation of a pan-Canadian health data strategy. This is one of our big efforts. It's really about negotiating with the provinces and territories around how do we build together a world-class health data system that allows us to share data, or at least enable federated data access to distributed data access to these data in order to enable the kind of analytic approaches that today's statistical approaches allow for, and the opportunities that it allows for, recognizing that we can all get further if we're able to do, for example, statistical analysis involving 40 million people in Canada, as opposed to even just in the largest province of Ontario, let's say 10 million people. So that is what's motivating that negotiation of a pan-Canadian health data strategy. The key is, as part of that strategy to develop it, the agency convened an expert advisory group that was chaired by Vivek Goel, who's now the president of the University of Waterloo. And that expert advisory group made it very clear that the barrier for what you're describing is not a technical issue. It's not a statistical issue. It's a governance issue. It's a culture issue. It's a policy issue. And so that clarity offered by the experts across the country has been then at the core of the negotiations between federal government and provinces and territories around trying to set up those foundations is what we're calling it, those foundations needed for a world-class health data system that would enable the kind of access to data to serve the interests of people in Canada, which I think is what you're describing, whether it's for a clinical context, like what Cam was talking about, whether it's in a research context, which I think is what you're talking about. Also, of course, for our agency, it's also about the public health authority context as well. And frankly, Canadians want it, right? Canadians want their electronic health record and all their health data in a place where they can control it, they can see it. If they move to another province, they take it with them, if they want to take it with them. So that kind of thing is, frankly, what Canadians are expecting of their governments. And so there's hard work happening right now to try to get there.
Great. Thank you very much.
I think next question from Professor Asghari, and then we'll move to you. Professor Asghari, if you could turn on your camera and or just your mic and ask your question, that would be great. Are you there? Okay, so then I'll just go to you before he comes back. Yeah.
Okay. Hi, thank you for your talk. So I just had a question, and I guess it's something that we haven't really talked about that I can recall in the session in the last couple of days too, but in developing and working towards this new future of public health surveillance in Canada, where, and also talking about marginalized communities and all of that, where do you see or have the indigenous communities and indigenous knowledge experts, have they been engaged, or how will they participate in this moving forward?
Yeah, thanks for the question. You know, in the Canadian context, it's clear that any agenda on data needs to take account of Indigenous data sovereignty. We're taking that extremely seriously. I'll be honest, I don't think we know fully how to do it. We know from a First Nations context, OCAP principles around ownership, control, access. That gives us a guiding framework. There is a First Nations Information Governance Center, great partners of ours. It's been amazing to work with them. But we also know that we need to not only take account of Indigenous data sovereignty, we need to take a distinctions-based approach in this space, recognizing that expectations of how data is treated and controlled and access provided will differ across Indigenous nations, across, for example, Inuit, Métis, and First Nations. So we that's sort of at the it's a core for us. I think that we've done quite a lot in this space. We have a long way to go, and it comes to the fore, for example, when thinking about, for example, the Pan-Canadian Health Data Strategy, currently in development and negotiation, because this is definitely something that the federal government's taking very seriously. We need everyone to take it seriously, because it will require changes to the way all of us are making use of and stewarding data. Because of course the data is not, it's not the government of Canada's data. It's not your, like when researchers having data, it's not your data either, right? It's the people's whose data it is. So that will require different models of collaboration, different models of stewardship. The good news is we have now some experience building in this. We have some amazing partners, such as the First Nations Information Governance Center, but we need to do more, and we are already working on it because we recognize it will take some time. Yeah.
Thank you.
Thank you. We now have Professor Asghari on the line. Professor Asghari. Thank you very much.
Great presentation, Professor Hoffman. Thank you very much. It was very insightful. I have a question. It's more. It may end up some kind of a global political issues, but I would like to have your opinion on that. Considering this worsening conditions of global geopolitical conditions, and the fact that, as you mentioned, This is something, especially for Canada and countries like us, very important to have this international global surveillance and, of course, collaboration and cooperation from one hand, and worsening of the situation from the other hand, and also as evidenced by the new report by World Economic Forum on global risks, considering that even this time infectious diseases is going lower in terms of global leaders ranking of risks, not because it is less important than previous years, but it is mostly because new risks are coming on the top, especially, or many of them are either related to climate change or related to geopolitical conditions that we are facing. I just want to know your opinion and your reflections on how this really impacts us globally while trying to achieve something better than what we had in the past. Thank you so much.
Yeah, thanks so much for the question. Yeah, I think in some respects, the worsening geopolitical situation, as you framed it, is making it more difficult to collaborate on these kinds of issues. Certainly, for example, I mean, even intergovernmental negotiations that would happen in our traditional forums, like through the United Nations, are challenged given all sorts of events happening around the world. I think, though, these are the kind of things, though, that more unite us than separate us. So, I mean, every society cares about health. Every person cares about their health. Every leader should care about their citizens' health and their residents' health. And so, in that respect, something like early warning systems, like the focus of this conference, is, of course, highly political. Data is highly, highly political. There's everything about it is politics. But the goal is one that is behind it, and leveraging data to advance health is a shared goal that can overcome differences in politics and culture. Frankly, we're all just self-interested, and from a self-interested perspective, we're all incentivized to try to build earlier warning systems because we all benefit from them. And to the extent that we, or have some countries not moving as fast as others, there's other mechanisms that are coming up to alert about things happening, whether governments like it or not. So in some respects, new technologies, new approaches, satellites, social media, it's making things more open. And so certainly Government of Canada has embraced sort of open government and is continuing to work in that space. And I think other governments are starting to see the writing on the wall on that as well. So I think the world is a complex place. Climate change, for example, a main driver of things, Ukraine, Russia, lots of aspects. But I think I guess I'm maybe naive, but I'm optimistic that this is an agenda that can actually unite rather than divide. And I think we'll get a bit of an early signal as to whether I am just being goodly optimistic or I'm naive in the context of negotiating the WHO pandemic instrument, because that will be a bit of a focusing opportunity to see, okay, to what extent can the world actually act on these most serious threats like climate change and overcome current challenges like what we're seeing with Ukraine and Russia. I hope that was helpful. It was not a, okay, I got the thumbs up, so that means I did okay. Thanks so much.
You did great. So one more question, but Cheryl from the Jane and Finch Community, Black Creek Community Center will not be happy with me. And I know I'm not supposed, I'm selfish to ask you a question, but on her behalf, I should ask this because you're the rep person on the seat here, and I should relate this to you. So we had Cheryl on yesterday, and she talked about new ways of surveilling diseases in communities where you have undocumented people that may not want to go to the formal system. You have people that are new to the country and don't know how things work. They may not go to the doctor. They may not have a personal doctor. And through their community, they have community ambassadors that throughout the pandemic, which they put together throughout the pandemic, volunteer and more from one building to another just to find out how people are doing. And through that, they are discovering new things. My question to you is, how is the Public Health Agency of Canada working with these community health centers to ensure that you adapt the way they survey diseases into what we have in the country right now? And the second question then will be on the global perspective that we're taking. You mentioned that out of the 64 surveillance systems that we have, 0.09 of them are just global. So 6% of them, 6 out of the 64. And so my question in that direction is, we have our agencies like our International Development Research Center of Canada that has a lot of experience decolonizing research and working with marginalized communities across the world. Is there a plan in place to kind of collaborate with agencies like that? Thank you.
Yeah, thanks so much. So the first question about community engagement and community-led surveillance, I think that's part of the future. We, as an agency, we are already currently funding many community health centers and organizations across the country, both for chronic disease as well as infectious disease contexts. I'll give you an example. In the recent Mpox outbreak, that was core to our strategy. I'd say, I mean, there are many pillars, but two that really come to mind are really the vaccination effort and the community engagement efforts. And we recognize that the Public Health Agency of Canada, we're not always the most credible voice in every community. We're not always the right messenger. And so how do we work with partners to do that? And I think increasingly we have to think of it not just as community engagement to support certain initiatives to roll out, but we also need to think about it as enabling those communities and empowering those communities to collect data in ways that is part of data justice, and that's advancing the things that communities care about for them to lead on and demand what they need from government to move forward. So I'm very excited about that. One maybe surprise, well, it was a little bit surprise to me, was that during the pandemic, myself and actually your next speaker, Dr. Marisa Creatori, we were invited to lead the development of the UN research roadmap for the COVID-19 recovery. And so in that process, that was working, it was a mandate from the UN Deputy Secretary General, and we were asked to identify in the summer of 2020, what are the top research questions needed to support a better recovery once we get through this thing. And when at the end of the process, the Deputy Secretary General asked me about what are the, if you were 3 lessons, I mean, we gave 25 top areas and like there's lots, if you haven't read that report, it's a good one. It won a design award for its formatting, but when she asked me what the top 3 lessons learned were, one of them, one of the 3 that I highlighted was how everywhere we heard, and it was 100 countries that participated in this effort, everywhere was around how we do not have the mechanisms to properly engage community during, whether it's it's during peacetime or emergencies. And so as a result, when things like a pandemic happen, we're never gonna have good responses if there's no ways of empowering communities with voice and to participate in those decisions as they're happening. So that was one of my the 3 key points that came out of that, which was a little surprising to me. I didn't go into developing that process thinking that was going to be a key conclusion, but it was. Jude, your second question, it was around the global
Perspective about partnering with our International Development Research
IDRC.
Center that has experienced working with marginalized communities across the world.
Yeah, I'm a big fan of IDRC, so that's International Development Research Center. In my previous role at the Canadian Institutes of Health Research, I worked very closely with IDRC. Your next speaker from CIHR, Dr. Creatori, will be able to probably talk about ongoing and future collaborations between CIHR, which of course is also, like the Public Health Agency, part of the Government of Canada. And so I think IDRC is an amazing jewel in an amazing way that Canada contributes to international development. And at the Public Health Agency of Canada, we do have a history of working with IDRC. Usually it's with also CIHR being a nice, important glue in that respect. And so I think hopefully that past effort will only be strengthened and deepened in the future. That'd be my personal hope.
Yeah. Thank you very much. You have a question?
Hi, Steve. Thanks very much. I'm Junling Ma from University of Victoria. I'm also one of the organizers here. Really appreciate you come and give this wonderful talk. So my question is, you mentioned that PHAC is actually aggregating or doing this integrated surveillance system with multiple components addressing different risks. And actually they're, especially with the One Health approach, we're expanding the boundary and more systems are integrated. And actually there are multiple early warning systems exist around the world that actually addresses the same risk. So it's a myriad of signals that could possibly come in. So I'm wondering how public health agencies would, process these signals and how actually best to pull talents from, different systems, different parts of the world to actually make proper decisions.
Yeah, thanks for the question. So I think that's what we're figuring out now. I think, we do have we have different programs within the agency. Each program is detecting and trying to understand those risks to inform prompt action. But what we're also doing at the Public Health Agency is taking a more centralized approach to try to not just interpret what an individual risk or signal might mean, but also to try to make sense of what multiple signals mean for how public health should be responding. I think that's where one of our big advances. But yeah, we're always trying to cultivate new sources of data and intelligence. Some of that, of course, needs to be through greater partnership with the academic community. So we're counting very much on you to help us do that, to figure out how do we filter signal from all the noise, because there's a lot of noise out there. But also increasingly pushing the boundaries. So, the 64 systems I mentioned, I'd say most, not all, but most are pretty traditional. That's okay, we need our traditional systems, right? But we're gonna need help to think about, okay, how do we push the frontier? I think wastewater surveillance is an amazing example because at the beginning of the pandemic, it was really research community led. In 2019, it was being thought of as this future, maybe in a decade, we'll be tracking spread of things through our waste. And with the need from the pandemic, it was given an opportunity to sort of be tested at scale. It proved very helpful. My point in sharing that, though, is that was the research community that can be really proud of itself. And there's many people across the country, maybe some of you, who are involved in that effort. That was, I think, a really important one, showcasing that in public health needs to deepen those connections with the academy to be able to more quickly develop, test, validate, scale, those kind of things in order to make use of them earlier rather than waiting 10 years down the line. Yeah, lots of different spaces, whether it's around text as data, for example, social media, whether it's integrating, for example, intergovernmental sources like diplomatic data with new scientific literature, which is, of course, as we all know, and we're contributing to, growing exponentially every day. We need your help to figure this out, but we're working hard on it.
Thank you so much. We will beg to go above a little bit just to ask one more question because it's not all the time that we get the Vice President of Public Health Agency of Canada with us.
Sure.
So thank you so much.
Thank you, Jude. Thank you for your presentation. I'm Bushan Nasri, one of the organizers of this event. So we have a question about the One Health approach. And you were talking about all the challenges around the governance of open data. And I was like thinking about all this One Health approach and the animal environment and human data. And I'm just seeing a lot of challenges around all bringing all those people together, especially that sometimes in the same agency or in the same in the same place, we have a lot of challenges accessing to data from some groups. So how we can just one day think that we will all share data among different different players.
Yeah. Thanks for the question. I know we're over time, so I'll try to be brief with my reply, which is that I think there's a couple of things. One is the need is so clear and present that the incentives to figure it out are high, in my view. So what's at stake for us to not do it is the consequences are so great, such as more pandemics, more disease, more disruption, such that we need to just figure it out. So I think that, and the fact that there's right now top-level political attention on this is actually, sometimes that's not helpful. This time I think it is helpful to break through some of those silos. But yeah, I'm not naive to think that this is just like deciding we're going to do One Health and then it happens. That's obviously not how it works. I do think we need to focus on sentinel issues, whereby if we figure it out on certain issues, we can learn from those contexts how to do that well and then apply it to other issues. Personally, I think, for example, antimicrobial resistance is the perfect case to apply initial efforts to take One Health approaches. Why? Because antimicrobial resistance is already killing a whole lot of people. It's already costing healthcare billions and billions of dollars. It's getting worse. Unlike most issues, which there's this sense of like continuous progress on things like antimicrobial resistance, also climate change. Those are a couple of the issues where actually the trends are going just bad to worse. So making it, I personally think, a really great issue to figure out how do we do One Health. Let's make some significant advances on that issue, and then we can apply to the full range of other issues. I think pandemics is another one, particularly given the stakes are especially high because we don't want to have to experience another COVID-19 pandemic in the way that we did. Yeah. Thanks so much again for inviting me. I so appreciate this invitation.
Thank you so much. And Effie asked the last question, which he insists that I should ask you. He says this. I'm interested in your thoughts about how to overcome the barriers to interoperability, especially linking existing data sets, starting with those that are owned and administered by governmental agencies. If addressing equity, is it important, for example, then that we should be making it a priority to link to those databases that have some of the key elements of the social determinants of health at an individual level. Also, it would be great if the surveillance framework being discussed at the federal level could focus on information as much as data. How has this need changed with the tools for action that are currently available? What is the different information that is required now without a need for information, which has changed in the last 3 years? Data have limited value in the surveillance context. I don't know if you want me to break this down.
No, well, I'll have to, because I will have to run after this question, so I'll just briefly answer. I think yes is the big answer, that we do need to link up data sets in order to better understand not just sort of what works or what's a problem, but for whom, in what context, under what circumstances. It's those we can't just stop at like, this is how we advance health of the average person, right? That's not serving all people in Canada. And so we need our data systems to actually be designed from the start and their core to be privileging those equity dimensions and those second order questions that get at recognizing we're all individuals. We're not just an addition of variables. We have these variables come together in intersecting ways. That means that we need to be able to have data systems that can support that kind of thing. I think one thing that I'm really excited about also is work that the Canadian Institutes of Health Research is doing, but with us and others around thinking about equity science and thinking about, yes, we need to disaggregate whenever we can, and we have to build our systems for data disaggregation. But if we're taking intersectionality seriously, as we need to, when you get enough variables and they're intersecting in different ways, we're starting to lose our statistical power as we go along. And so thinking of new approaches, and again, I'm talking to mathematicians here, so I'm both humbled, but also trying to encourage you to think about how do we take this recognition and demand from citizens to be treated not as a series of variables, but actually recognizing that people who that the intersection of these different variables have fundamentally different experiences than those who are finding themselves intersecting with other environments and circumstances. How do we do that in ways that still allows us to draw actionable insights? And so I think I'm really excited about that. I think it will require some fundamental changes in the data infrastructure to enable it, but we also need people like you focused on figuring out the math behind how do we continue to better understand the lived experiences and realities and expectations of people who are coming at and experiencing a world in very, very different ways. So I think that's the future where we need to get to. We're not yet there. We need your help. So yeah, thanks so much.
Thank you. We need your help. We need collaboration. Please, let's put it together for all those guests.
Thanks so much.
Thank
you so much.
Really appreciate this.
Of course. Thanks so much.
So we'll have a break now, and then we'll come back at 10:30. Coffee break.